Welcome everyone to today's webinar. I am Abby Krause with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our moderator, Jason Crawford, Chief Executive Officer of Intelligent Retinal Imaging Systems. Jason, I will pass it to you.
Yes, hello and welcome to Preventing Diabetic Blindness, solving the lowest scoring quality measure by providing diabetic eye exams in primary care. I'm happy to be your host today, and we have the pleasure of being joined by two great leaders in healthcare delivery to share their story. We can advance to the next slide. Today's goals are to listen to a health system and a medical group talk about operationalizing a scalable diabetic retinal program in primary care. We focus on how you can implement a similar program. Want to be really facilitative, so use the question and answer feature that you have there in the webinar, and I'll be facilitating the questions as they come in, because really the takeaway should be if you have a population of patients with diabetes that you'd like to tackle, we'd love to share these best practices with you so that you can be more equipped to run your program. And then the last bullet point is understand how the IRIS and EHR integrations really improve workflows for not only patient identification, but streamline the exam process and then also reimbursement. So as we advance to the next slide, we're going to really focus on diabetic retinopathy today. There's a lot of things in teleophthalmology that can be done, and we will do. But as we look at really the challenges of diabetic retinopathy, it's really a population health challenge. And as we've traveled across the country now with installing these programs in 105 health systems in about 30 different states, we realize that the research is accurate. There are a challenge with less than 50% of patients achieving their retinal exam annually. And then we know, and as we focus on what the health systems are telling us are very important to them, we're willing to find these patients, give better access to the patients. And so whether it's in the primary care setting, a retail clinic, or even in the home, closing care gaps, the idea is to mobilize the diabetic retinal exam so that we can really better reach the populations of patients that we're in charge of taking care of. So next slide, today's presenters that are going to be joining us is Dr. Youssef Khalifa of Grady Hospital. Dr. Khalifa is Associate Professor of Ophthalmology for Emory in Atlanta, Georgia. He is the Chief of Service of Ophthalmology for Grady Hospital and has been running the program there that was implemented a year ago, back in September of 2016. Has great direct experience of what it took to get the system live there, and as well as the operational efforts that he's deployed there within the health system. And so, good opportunity to talk with Dr. Khalifa. And then Dr. Anas Dagestani is the President and CEO of Austin Regional Clinic in Austin, Texas. Austin Regional Clinic has a very rich history of population health management. It's a multi-specialty clinic, and so Dr. Dagestani has previous experience with trying retinal exam programs before IRIS, and so he can speak to over the last 2 years, I think August of 15, when they first began to scale the system there. And so we'll start with Grady Health System, and the next slide is going to be the introduction here for Dr. Youssef Khalifa, and we can advance one more slide and turn it over. Youssef, go ahead.
Thank you, Jason, for having me, and thanks to Becker's for hosting this. Here at Grady, we had a huge problem. I started as Chief of Ophthalmology back in 2014, And we were seeing a lot of patients coming through the emergency room with neovascular glaucoma, end-stage diabetic retinopathy, vitreous hemorrhages, so on and so forth. A lot of avoidable blindness in the Grady healthcare system. Grady is the main inner city hospital, public safety net hospital in the city of Atlanta in Georgia. The primary care clinics at Grady are responsible for over 175,000 lives. We have the main Grady hospital with 4 primary care clinics, diabetes clinic, and then we have 6 neighborhood health clinics that go throughout the metro Atlanta area. And we're committed to providing healthcare to the underserved population of the metro Atlanta area, specifically in the counties of Fulton and DeKalb. Next slide. Can we get the next slide? Yeah. So when we first started and we started looking at the population of diabetics in the Grady healthcare system, we looked at many different ways of trying to get our arms wrapped around the actual numbers. And it can be very difficult to figure out how many diabetics you have in a system as large as Grady's. We're somewhere between 15 and 30,000 diabetics, depending on what ICD-9 codes or ICD-10 codes you're looking at. And we looked at pharmacy prescription refills, but we felt most comfortable with a number about 25,000 diabetics in the system. And if you look at our compliance with screening for diabetic retinopathy, we're only at 44%. And our clinic, the Grady Eye Center itself, looking away from the primary care clinics, but the Grady Eye Center itself, we had a backlog of 14,000 new patients to be seen in the clinic. And when I dug deeper into that number, a majority of those were diabetes patients who needed eye screenings. So to improve the delivery of care and access to care at the Grady Eye Center, we had to address the diabetic population and their need for eye exams. And when you look at implementing a system for a diabetic screening system for a healthcare system that is as complex as Grady, you really have to have the integration into electronic medical records. You have to have the automation with billing. You have to have the ability to generate referrals on ongoing automatic basis, and then the ability to track performance. We can walk through that in the next slide. If you can go advance the slides. So the workflow optimization, if you look at the number 1 there, that involves where to put the camera, where in the clinic to place the camera, who to train, the CMAs, the certified medical assistants, and what their roles are going to be, the protocols for when to dilate a patient, and then there's also the front end work you have to do with the electronic medical records so that you develop these BPAs, best practices alerts. And you really have to get in there, get in the nitty gritty on what exactly is it that you're looking for the alert to fire, and having the patient lined up in the queue for an examination that day. So all that goes on the front end. We spend about 4 to 5 months planning out how to deploy, where to place the cameras in the clinics, how to integrate an electronic medical record, developing a referral protocol for when they need to get into ophthalmology. The second box you see there, diagnostic optimization. This has a lot to do with which camera you decide to use. Are you getting a handheld camera or a tabletop camera? How many different clinics are going to be serviced by one camera? How many patients are in the different clinics? And then you're also looking at how you integrate through DICOM up into the cloud. What happens on the technology side with the image enhancement, the auto grading, so on and so forth. And then the last part is the analytics, and we get we have a weekly report that by camera, by location, we know exactly what the diagnoses were for all these different patients, and we monitor that very carefully. And we can go to the next slide. So if you look at our the analytics for the Grady system, for the fiscal year 2017, we've screened 5,300, almost 5,400 patients. 41% had some form of pathology. Now, bear in mind, this is not all diabetes. Cataract, macular degeneration, glaucoma, epiretinal membrane, so on and so forth. There are a lot of different things that the readers can find on the examination. Not all of that 41% is diabetes. Of that 41%, 25% had early identification of diabetic retinopathy. And then 6.3% had advanced diabetic retinopathy that was caught. Now, if you look at diabetic retinopathy, there are different stages for it. There is the non-proliferative stage, which is graded as mild, moderate, and severe. And then you have, if you get past the non-proliferative, then you get into the proliferative. That's where you get into some serious risk for tractional retinal detachments and significant vision loss, as well as vitreous hemorrhages and neovascular glaucoma. So you obviously want to catch the patients earlier on in the diabetic retinopathy spectrum and avoid the proliferative diabetic retinopathy. Now, we had a very high percentage of patients caught with proliferative diabetic retinopathy. I think the national average is something like 1%. We were at one point cruising at 5%, and we're down to 3.1%. But that just shows the need that we had in the Grady system, that so many patients weren't having access to eye screenings, and therefore we had a very high level of burden of disease. I think that's the end. Is there one more slide for me, or is that it? Can we see the next slide? So this is looking at our HEDIS compliance scores, and obviously you can see that we basically flipped the graph, from our non-examined in the red to examined in the blue, and we've dramatically increased our compliance with screening, and obviously this has financial implications that administration here at Grady is extremely interested in. Obviously, patient care and avoiding blindness is of utmost importance, but if it doesn't make financial sense, it's very difficult in a resource-constricted place like Grady to allocate dollars to something like this when you have a burn unit and a dialysis unit and so on and so forth. So financially, it has there's been a good ROI for Grady. And next slide.
Dr. Khalifa.
All right, I look forward to hearing your questions. Thank you.
Yeah. Hey, thank you, Dr. Khalifa. This is Jason Crawford back here again. So, 5,300 patients in the first year of your program has been, obviously taken off and really gotten a lot of access to those patients very quickly. What would you say, kind of looking back, on this year? Give us a couple of, maybe the audience, a couple of decisions that you made. So, early on when you decided to launch the program, talk about the selection of equipment and how you were thinking about which equipment to use inside the clinics.
That's a great question. We're actually going through the same exercise with Emory healthcare system right now, and they're relying on our experience at Grady to figure out what to do. You have a decision: are you going to go with a handheld unit or a tabletop unit? I'm always worried about these handheld units. As an ophthalmologist, I remember taking call as a resident and going to the emergency room with a portable indirect ophthalmoscope and dropping it and breaking it. So I have a fear of these, these portable units and the risk of breakage, and then having downtime. So if you break the unit and there's no replacement for a week, then you have a wasted MA. This MA FTE is not being utilized. So we made a decision to go with tabletop technology. Now, when you get to the tabletop, then you have to decide, are you going to use a mydriatic or non-mydriatic camera? Mydriasis is when the pupil is dilated. So we clinics with drops like tropicamide and phenylephrine and so on and so forth. A non-mydriatic camera is able to capture a picture of the retina without dilating the pupil. So we decided to go with a non-mydriatic camera, and this technology, the ability to get non-mydriatic photos, has made teleretina diabetic screening in the primary care clinics much more feasible. Before this technology was available, this really was a very difficult process. I know the VA has had a teleretina program up and running, and they relied on dilation protocols and having to check pressure and visions and so on and so forth. But with the non-mydriatic cameras, you don't have to check intraocular pressure just because you're not dilating and risking going to angle closure glaucoma. So those are sort of the things. we looked at when selecting a camera.
Yeah, no, that was really good, and I remember that process, and it's interesting now doing the same process with Emory. It's the cameras that you chose in the Grady system with, I think, the center view Aiden camera, and that camera costs more. I think it's about a $35,000 piece of equipment. Meanwhile, on the Emory side, they look at their clinics. We might use a lower cost, $15,000 tabletop, unit, maybe from TopCon. But we're also talking about using handheld equipment in some of the other clinics. And so I think the point is that, for those of you listening, as you consider your locations, you can be flexible on the technology and being able to have a platform that integrates all of those different types of camera systems, because it's all about asset utilization. If you have more utilization, you can probably afford a bigger system, and a little bit of workflow optimization too. Youssef, we have one more question here. I'll facilitate this question. Came in from Thomas, and let me read it to you as I update it here. So, Dr. Khalifa, how do your clinicians know, or how are they notified when a patient needs to have a diabetic eye exam care gap closed?
So the question is, how does the primary care doctor know that the patient is due for a screening photograph? Is that the?
Yeah, I think exactly. I think it's getting to the workflow, like the medical assistant, the best practice alert, and how that's working to notify people.
Yeah, so you really have to look at your electronic medical record. So within the Epic ecosystem, and that's what we're on here at Grady, Epic has something called a best practices alert. And primary care, they have a lot of different best practices, like when do you start a beta blocker, or when do you have a patient on, when do they need a flu shot, so on and so. These are called BPAs. So we had to build out a protocol for the best practices alert for the diabetic retinopathy population. And what we ended up doing was saying anybody with these ICD-10 codes, diabetes, all the different ICD-10 codes for diabetes, if they have an ICD-10 code, then the electronic medical record goes back and looks for the CPT codes for either an eye exam or for a photograph. So 92014, 92012, 92004, 92002, and then the photograph, which is a 99250. And if it doesn't find one of those CPT codes in a patient with an established diabetes diagnosis from the ICD-10, then the best practices alert will fire. And that's for a calendar year, because that's how HEDIS is graded, is for a calendar year. So as soon as December is over and January starts, then all the CPT codes are basically wiped from the search algorithm.
Great. Yeah, so that's important. And then so getting that workflow into the medical assistant or whoever is. So as you're thinking about designing programs, always be thinking about how can we do this without the workflow being burdened on a physician or a provider. And so with the use of best practice alerts, or in some of our other EMR integrations, we have identified when the patient checks in at the front desk, it flags that patient for the test. Whatever the system is, leverage that, and then also put in a standing order, protocol order, or whatever your health system is comfortable with, so that the medical assistant or your patient care technician can capture those images while they work the patient up at the beginning of the visit. So, well, thanks for sharing that. There's some other questions coming in here, and I'll facilitate those, but let's first go to Dr. Anas Dagestani. And Dr. Dagestani, tell us about Austin Regional Clinic and how you approached your situation there.
Sure, thank you. Good morning or good afternoon, everybody, based on where you are on the East or West Coast. Thank you to Jason and Iris, and thanks to the Becker Hospital Review for hosting this webinar and allowing us to share our story. If I might go to the next slide, please. So Austin Regional Clinic was founded in 1980 by 3 primary care physicians, grew over the years to 300 physicians, spread over 22 locations. providing care to about 450,000 lives in the larger Austin metro area, basically, and the surrounding county. What's interesting about Austin Regional Clinic also that we started in a global capitation world. So between 1980 to 1999, Austin Regional Clinic took full global risk for 80,000 commercial lives with multiple payers. As the payment methodology and interest change, we went back into fee-for-service. In 2010, we started our journey going back to our value-based care. I'm missing a zero there on the slide that you see. We have 220,000 lives under different ACO arrangement, from Medicare MSSP Track 1 to Medicare Advantage, commercial ACOs, and Medicaid ACO. So that's just history and background. Next slide, please. So as we're starting to build our infrastructure, and as we start to reignite our DNA and look at areas that we do well and area that we don't do as well, it became very clear to us that we don't do as well when it comes to diabetic retinopathy. Our original screening rate, and we started looking at this more than 10 years ago, no matter what we did, from sending the patients a letter to communicating with our physicians to making phone calls to making local campaign, regional campaign, we stuck between 35 to 40%. And I think that's actually a common experience around the country. But when we look at how we do on blood tests, meaning our ability to get our patients in the clinic and get their blood test needed for diabetes, we do over 90%. So it became clear to us that this is a technology and a workflow issue. If we're able to get our diabetic patients in the clinic, and we have about 15,000 of them, and get their blood tests in over 92, 93% of the time, then why are we stuck at 35% screening rate? Justin alluded to different trials with different cameras, and part of it was the technology was not available, and part of it was the service, the wraparound service that we're going to talk about was also an issue. So we set out with an objective to improve our screening rate and follow up, not only the screening. You read a lot of national literature and publication and concern about it's good to improve screening rate, but only if you're doing something about it. So that was our second objective. We wanted to intervene early, obviously from a good care, but also to control the cost of care and to work with our patients and the employers in our area to avoid loss of productivity and blindness. Next, please. So again, the challenge it was basically technology, access, service, and cost of implementing. We're a multi-specialty group. We're physician-owned. So you know, money unfortunately doesn't grow on a tree for us. So we have to do our best. But also the challenge on the patient side is also the lack of symptoms with a disease like diabetic retinopathy, where you can go 10, 15 years undetected until it's late in the game. And then how do you share that information with a primary care physician? Next, please. So we decided to bring diabetic exam or diabetic retinal screening into our clinics, basically. We started with a pilot of one camera about 2 years ago, expanded quickly to 3 cameras, and now we're up to 9 cameras into 9 different locations, basically. And the idea overall that it's integrated within the EMR. I think we've heard from Dr. Khalifa and the Grady system. We are also on Epic, so we used similar tools of creating an alert in the system. It's a sort of a pop-up, if you will call it that. It's a best practice alert in the Epic world, but it's an actionable pop-up where the physician can click accept and automatically drops an order in the system, so they don't have to go and look and find an order. Basically, We housed the cameras into our lab area. We didn't put it in the clinical area with the physician or the nurses. We actually put it in lab and train our phlebotomists to do it. And again, our theory there that we're getting our patients to get their blood draw done for diabetes 93% of the time. If we can do it at the same place, then chances are we're gonna be successful. Basically, we depended on Iris connectivity with a local high-quality retinal group, and all of that was integrated within the EMR. So the way it works is very seamless. A patient shows up in the clinic, the physician sees the best practice alert, they click accept when it's basically applicable, it goes automatically to the lab, patient checks out on their way out, they get a retinal scan, it goes through the cloud secure connection to a retinal group, and then the reading are back electronically in Epic literally by the end of the day, and we have actionable information. And then I'm going to talk later about some of the screens and safety filters, because this addressed the screening rate but does not address the follow-up rate so far. Next slide, please. So what we've done is we've noticed that we're doing close to 6,000 a year across the initial 5 sites. As I mentioned earlier, we're up to 9 right now. What we're discovering, about 20% of a diabetic retinopathy rate. And within that, there is a 1 to 2% of severe retinopathy that basically could have went undetected until it's more severe. We're also able to capture other pathologies that the cameras, help highlight the presence of other pathology, basically. So what we've seen so far, just about less than 2 years into it and limiting it to only 9 sites with a plan to expand, is more than 20% improvement in our screening rates, 70% improvement in our follow-up rates, and I want to spend a couple of minutes talking about that specifically. So we've taken a few steps. One, we've allowed the retinal specialist, the way we transfer the information to them, to reach out to the patients on our behalf as well when they see moderate or severe retinopathy. So that was one filter. We've worked with Iris on getting reports of showing patients on a clinic level or on a group level that have had an abnormal results, and we compare them to the claims data that we get from the health plan. And if we see a 30 days between abnormal results and no ophthalmology claim coming, then we will reach out to the patient. We centralize that to one place. Then if we see 90 days that passes, then we send a certified letter to the patient. And that have helped us, close the follow-up rates basically on abnormal results. What we've seen with that also, as we participate in a Medicare ACO and a Medicare Advantage ACO, that we see our ACO performance, which have an impact on our shared saving, continues to improve. We think that's going to help us when MACRA takes an effect, or when MACRA start impacting our fee-for-service Medicare in 2019. And we see an impact on the star ratings of the Medicare Advantage plans that we're working with. Next slide, please. So from our experience, and healthcare is local, the key to success on our side was, one, providing on-site access at the primary care clinic in our lab area. And again, it's our theory and observation that we're getting the lab done, so we want to do it at the same place. A stable and predictable and reliable technology. We have not had any issues with any of the cameras. The integration between the EMR and the workflow and the camera and the retinal specialty practice allows us to do data collection, repeating the communication with our physicians and nursing and lab personnel, the partnership with Iris, and the emphasis on follow-up treatment. We think those points played a key role in our success. What's next on our radar? We're planning to expand to other sites, and we want to actually provide practice level results to each one of our physician and blinded to show them, give them insight into their practice, and comparing them to others within the same building, within different practices to encourage discussion and to a degree competition as well. Next, please. I think that's it for my part. Thank you.
Sure. No, that's great. Let's go back to a previous slide there. Just go back one slide. So, Dr. Dagestani, I've been just impressed with your group as you've done this and how you've really objectively looked at each thing. You wanted to see outcomes early on, before you expanded. So let's start with, and I'll facilitate a question from Pam. Let's start with the early decision. So Pam writes, how did you work on the pro forma? What was your time frame on recouping your investment? And so, early on when you first thought about doing this, what were some of the thoughts that you put into it? And then when did you see that return that gave you the confidence, let's go ahead and expand this to the rest of our clinics?
Sure, thank you. Thank you for the question. So the question is the pro forma, what led to this decision? So obviously I talked about the clinical identified gap. We knew that that's an issue, but we knew that unfortunately in the fee-for-service world, sometimes you get punished for doing the right thing. So we had to run a pro forma. We knew that as the payment system transitioned to value, there will be definitely a return on investment, but that was, an after effect, basically, or after the investment. So we looked at the cost is mostly the camera itself and the initial implementation. And when we checked with all of our payers and partners and looked at the number of diabetics in each clinic and work with our finance folks, it became very clear to us that this is not going to be a source of significant ancillary revenue, but it definitely is going to be more than a break even. And it takes almost a year or so to break even after the initial investment in the camera. That does assume a certain concentration of diabetics. So this, the larger the clinic and the higher concentration of diabetics, the more the pro forma works better. The smaller in the clinic and the lower concentration of the diabetic, the more it becomes closer to break even.
Mm-hmm. That's right. And the second part of Pam's question, I think, is a good one too, which is she asked, did you ever have difficulty having insurance reimburse the test? And as you and I have worked on this over the last 2 years, I know that the majority of the time you've had positive reimbursements, and there have been at least one that I know of that you've been working on. But talk a little bit about, have the majority of the folks reimbursed the 92250, that exam code? How's your experience been?
Thank you. So the question regarding to reimbursement and was it consistent and was it easy? So I would say that before we implemented part of our evaluation, we checked with all the payers, and we've all been in a situation where the initial answer is yes, but once you implement, there's yes, but. So it was 70% yes, and I would think from day one, 70% of our payers, I would say Medicare for sure, and all commercial payers did not have an issue with it. I think with the Medicare Advantage plans, we had to do some education and back and forth. About a year into it now, we have a pretty much everybody with the exception of one small Medicare Advantage plan that have made the decision that because the camera is located in a primary care office, that it does not meet the requirement. We've actually done a lot of work and reached out to NCQA and to Medicare, CMS, to confirm that our assumption is true, that this can be done in a primary care office as long as it's read by a retinal specialist. And the answer was yes. So I would say for the most part, reimbursement have not been an issue. It was us and others probably worked with Iris and helped clear some of those obstacles for anybody else that want to implement a technology like this. But at this point, we're in a good position.
Mm-hmm. Good. And so I'll facilitate a few other questions. And a couple of people asked this question, but Carrie writes, once the image is taken, who completes the interpretation? ? Retina physician ? And I'll answer that, Carrie, and a couple of others of you that asked a similar question. The requirement for quality, so NCQA and the CMS requirement, is that the interpretation is completed by an eye care provider, which includes retina specialist, ophthalmologist, or optometrist. And the telemedicine guidelines require that that interpreting physician be licensed within the state that the primary care, and the service is delivered. And so you can do that in a number of different ways. And our model is to be flexible to the health system because every health system is different, and we want to facilitate that. You've got the opportunity to have your own ophthalmologist interpret that. So if you have your own employed ophthalmology group, if you're an integrated system. Second, you can work with a local retina group. And so the example here with Austin Regional Clinic, they worked with a local retina group to do the image interpretations. And so Iris then works the contracts with that group, gets them credentialed, gets them access to the online interpretation platform, and then we share quality outcomes and analytics back to that retina group on how long is it taking you to interpret the image, and then a quality assurance check that the interpretations that are being completed are within compliance of normal ranges of pathology. And then the third option is that if you don't have an ophthalmology group, or if the local eye care resources are consumed with other things, then you can use the Iris Reading Center. And so we've set up a medical group that meets all of the telemedicine laws across the country. And that's the example of Grady Health System. They decided to use the Iris Reading Center for their interpretations. And so we provide that in those services. And so that's a great question. Let's see, Dr. Khalifa, there was another question here that I think that could be good is how do you staff the equipment? And so, when you think about who's actually taking the images, is that a dedicated staff member, or does that staff member have other duties? How did you decide how to make sure you have, the staff to do it? I'm sorry, Dr. Dagestani, if you could help answer that question.
Sure. So we basically house this in labs. So we basically worked with our lab staff. Basically, we did not use RNs or MA. It was a workflow decision for us. We wanted the camera to be staffed all the time and not to have to flex staffing to pull them from doing something else. The education part was easy because this is very simple. It's really a push of a button. You just have to make sure that the position is correct, and it takes less than 30 seconds to complete. And we did a campaign, kind of a lunch and learn in every clinic. One, to share with them why we're doing this. It's not a plot to increase their workload. It's really we're trying to improve patient care, and that resonated very well. I think our retake or a situation that you're not able to get a good scan is actually less than 5% overall, and that's spread at 9 different clinics. So that's a pretty good result. The training is really 2 to 3 days on site that Iris helps with training and staying on site to train the staff. Good.
Okay, those are great questions coming in. I think we'll do a good job to keep doing this and answer these questions that are coming in. So that way we get right to what the questions are from the audience. Let's see, I think a couple of questions here about CPT codes and reimbursement, and I'll help answer those. So Rachel writes, which CPT codes are you recommending for your customers? And then another question, I'll follow on that. So Rachel, what we've done from IRIS perspective, we are not in a position to give professional advice on reimbursement and coding and billing, and so we do the best job we can just to educate the customers. And all of our customers, we have 105 of them now that are health systems and medical groups like the two you're talking to. They've made the decision. Just looking back, I can share the data with you. Those groups have each independently made their decision, and they are using 92250 retinal imaging with interpretation. And we encourage our groups to talk to the payers, before they make that decision. And then we've been very closely working with each of our customers to talk to the payers. But I think at the end of the day, we've gotten the reimbursement has been very good because the payers are actually really excited about this service. It allows them to find those patients that have disease that they're going to end up paying a lot of money for, specialty drug therapy to treat the disease. And so they want to find it early if they can. It also helps from if anyone is in a risk-adjusted payment scenario where, as you increase the HCC score and you have the RAF capture, then obviously there's going to be more reimbursement to take care of that sicker population. And so that has been the help. And there was a question about whether or not CMS and Medicare are reimburse that code. And that decision is actually being made at the local MAC area. And so there are a couple of MACs. One that jumps out to me is First Coast, which does traditional Medicare reimbursement for the state of Florida. They have decided not to reimburse that code. So unfortunately, I guess patients with diabetes that are in Medicare in Florida are not going to be reimbursed. But if you're in Georgia, Alabama, or Texas, or a lot of other states, the reimbursement is happening. And so it's a MAC by MAC decision, and I think that should be consistent across the board. But I don't think we're quite there yet for CMS to make that decision. Let's see. I'll try to facilitate a couple of other questions, and Anas, jump in here if you have anything you'd like to share. What percentage of your customers are using tabletops versus handhelds? Question in from Melinda. And it's interesting. Before this year, the majority of customers use tabletop cameras. They're much more reliable for good quality image capture. And so you want to make sure you don't have a high non-gradable rate of images that are kicked back by the interpreting physicians. But we've seen this year an increase in the handheld cameras, and I think that for looks like that the percentage of handheld cameras is almost up to a 50-50 of the tabletop. But a lot of those handheld cameras are also going into mobile environments, whether they're on a bus that's traveling to different locations or going in the patient's home and doing closing exam gaps in the home. So still tabletop is the majority for those that are doing it in the clinic. Another question about how to get that equipment. So yes, you can purchase the equipment, but we have programs where there's no upfront initial cost. And so I think Rachel asked the question about lease options or other options. We believe if we can reduce the burden for that initial investment and spread it out over the cost over a contract period, then that's going to allow more people to take advantage of these programs. And so, yes, we have flexible options on the equipment, and depending on the scope, we'll work with you there. Let's see. Dr. D'Agostani, here's a question that relates to, closing the gap. One of the things that you shared was that, getting the exam done in the clinic is one thing, but what do you do for follow-on care? And so, let's see, Nita asked the question, that, how have you coordinated the follow-up care, and what are some of the challenges in getting patients to follow up with their care once you find that they have disease? Can you share just a little bit more about the approach you took there in your market?
Sure. So, I mean, we really did a Swiss cheese model. We don't have ophthalmology under our roof, so it's going to be a little bit of a fragmentation and less control of the situation as we'd like to. But historically, it's obviously the primary care physician seeing the abnormal results and then calling the patient and saying, you need to see your ophthalmologist or you need to schedule an appointment. So that still happens. We're still depending on that patient-physician relationship. But we've added, as I said, 3 filters to it. One is actually allowing the retinal group that treats those scans to reach out on our behalf as well to say, our doctor just read your scan. If you have an ophthalmologist that you see, please see them as soon as possible. If not, I can book an appointment right now. So that's one filter. 2, we generate 2 reports, one at 30 days and one at 90 days, and centralized to one person within the group. Those are the report of patients who've had an iris scan that came back abnormal and with no evidence of a follow-up with ophthalmology based on what's coming into the EMR or the claims as we get the claims from the health plan because of our ACO contract. So at 30 days, we call them. At 90 days, we send a certified letter. And that has helped us move our follow-up rate from also the 30-35% to around 70%.
Yeah, that's great, and that's some of the best practices, that we've seen, and that coordination of care has really been key. Along that step, what have you seen about the how you ensure that patients understand that this is an initial diagnostic test? I think Abby is asking a question about patient education, that this is an initial diagnostic test. It doesn't replace the fully dilated eye exam, but since you haven't had your retinal test this year, we're going to go ahead and get this test done here in primary care. How do you message that education for your patients?
Yeah, thank you for the question. So the question is about education, that this is a screening test and not a diagnostic test, and how do you educate and who do you educate? I think that's something that still bubbles up every once in a while. It was a significant education and recommunication with our physician to basically just make sure we're giving a consistent message that this is a screening test and does not negate the need to see your eye doctor. We also clear about the situation if the patients already have an established ophthalmology relationship and we're seeing reports coming back from ophthalmology once a year that we're not doing this test. That's part of the best practice alert. That best practice alert is scanning the EMR, looking if there's been already a retinal scan in the last 11 months or an ophthalmology consult or a claim coming from ophthalmology. And if any of those there, then it turns off. At least once a quarter, we get a patient who's calls us and say, that's not fair, I've done the screening test and I went to my retinal specialist and they did another one and they said it looks okay. We use the analogy of a mammogram. If the mammogram and 6-7% of the time is false positive, that doesn't mean you stop screening the whole population, because you're going to run into 6-7%. Otherwise, we're going to have double, quadruple the risk of breast cancer. We found that to resonate well with patients because everybody have mammogram embedded in their mind or any cancer screening. So we use that analogy that every test, no test is perfect. You're going to have a built-in false positive and false negative, but you cannot throw the test out of the window because of that, and that resonates with people.
Yeah, better to do it than to let them go through and not have it done, and that's a great approach. Okay, one last question as we and then we'll close out here. We've got a question from Kevin. What do you see as future in using machine learning and advancement in diagnostic algorithms to aid and improve the accuracy of analysis of your retinal images? So Kevin, that's a good question. And the use of machine learning and AI is getting so much stronger. And when you look at the number of images we've captured now, so over 200,000, we have over 211,000 patient exams that we've completed. So our database of images is approaching 500,000. So with 500,000 images, we've now been working on using machine learning algorithms and AI to provide very accurate, actually on the track of state-of-the-art, accurate image interpretation right at the point of care. So the idea is that right there at the camera, having an algorithm be able to do an auto detection that allows for the patient, the physician, the treating physician that's in the clinic with the patient for their primary care visit, to understand, does this patient have sight-threatening disease or not? And that's exciting. That is live with one of our customers today, and is on the verge of being rolled out throughout the rest of our customer base. And we're partnered with Microsoft to deliver that technology within the cloud environment. And so it's within the BAA and within our security clearance and assessment. And I think it's going to change the way care is delivered. Not only can you then, take action for that patient on their next steps of care. Do they need to see a retina specialist? Do we need to get that scheduled right away? But you can also engage that patient and look, you're really at risk here of losing your eyesight if we don't get the rest of these things in control. But thirdly, and where I think maybe even the most opportunity is what happens now when we begin to correlate that back to how tightly controlled that patient is. It's not just their hemoglobin A1C that we need to look at, or their lipid panel and BMI and other indicators. We also need to be looking at the microvascular damage in the eye. And that's the advancement in the road that Iris is on. We envision the role that we're going to have in the way care is delivered in the future to make all of that data consumable right there at the point of care. So thanks for that question. We have a lot of other questions that have come in, and we want to facilitate all of those. And so we'll follow up via email back to you, and would love to connect and brainstorm if we can help you think about how you design your program, what technologies you're going to use in your program. Hopefully you can learn from these examples that we've had and these other health systems, the medical directors and the staff that have kind of labored before you and taken a lot of the punches, so that now we can leverage that into best practices for you and your group. And so I'll turn it back over to the Becker's team. I appreciate Dr. Dagestani and Dr. Khalifa for sharing your story with us today.
Thank you very much,
Jason. That is all the time we have for today. I want to thank Jason Crawford, Dr. Youssef Khalifa, Dr. Anas Dagestani, and Intelligent Retinal Imaging Systems for their excellent presentation, and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you. Bye-bye.